Cool. All right. Well, why don't we kick it off with just some quick intros? Alejandro, I'll start with you. Do you want to give just a quick background?
Definitely. I'm Alejandro. I work at product. I've been building products in the intersection of money, technology, and care delivery for the last 11 years. And I've been lucky enough to work with Megan. So maybe we can pass it off there.
Yeah. Hi, everyone. I'm Megan Struxness. I've been in the revenue cycle management space for about 13 years now, starting from patient intake registration, insurance billing, into more of the strategic side. And I've been in the digital health space world the last, oh gosh, about 8 years, I think. Yeah. And I'm currently in a stealth health startup, but worked at Doctor on Demand prior, as well as Brightline, as well as Virtual Radiologic. So yeah, excited to be here. Allie.
Awesome. Thanks, Megan. Hi, everyone. My name is Allie Eschbach. First and foremost, I just want to put it out there. I caught a cold this week, so I'm going to try to keep coughs and sniffles to a minimum. But I am a senior director at Cedar, which, for those of you that don't know, is a health tech company focused on the patient financial experience. Prior to coming to Cedar, I worked in revenue cycle consulting, doing performance improvement and software implementations in the rev cycle space for provider organizations throughout the US. So I'm very familiar with the space and excited to be here today.
Awesome. Well, great. Well, let's get going, and we'll start right at the beginning. So Alejandro, I'll start with you. Let's say you're setting up a provider organization that's going to bill insurance on a fee-for-service basis. What are the first few things that you do to start preparing?
I think that there is always first a discovery of like, are you actually talking about revenue cycle, or you're trying to figure it out what your business model is? And that line is extremely fragile. This is about pressure testing. Like, what do you mean when you say fee for service insurance? Assuming you end up with the most traditional example, which is we're gonna get in network, we're looking for the provider rates, and we're gonna have fee for service, just appointment-based billing. Then we tend to follow a model of looking for the member experience. So basically, how many of your patients will hit which part of revenue cycle the fastest? And hence we go, well, it looks like the first thing they got to do is figure it out who we're in network with. So those are the contracts that we're looking for. Figure it out whether they actually have coverage for our product, and that's eligibility. And then we actually go down the pipeline in priority very quickly, where we'll get into coding, billing, denial management, refunds. But you can see how the number of humans goes down significantly. So it's all about, let's make sure we get registration, contracting, pricing, and eligibility right. Everything else will figure itself out at the beginning.
Got it. Got it. Cool. And Megan, from a resourcing perspective, what would you look to bring on in the early days, assuming you're not an RCM expert yourself? Are there any external vendors or contractors in particular you'd be looking for? And would you even think about hiring anyone right out of the gates?
Yeah, it's a great question. I love, we didn't even rehearse this, Alejandro, but you teed my answer up here very perfectly. So I think really looking at resourcing comes into play of oddly, like step one is actually starting at the end. And it's really understanding what the insurance claim is and how it functions, because it's very different than what I think is more the better understood credit card transaction that you have with your cash pay population. And so I would actually start there, which is the insurance medical claim is the end product of a visit that you want to bill fee for service. Within that insurance claim, you'll quickly be able to learn what are those data elements that are required to go on a claim to actually receive successful reimbursement from your insurance plans based on your contract. And as Alejandro indicated, from that, you can start to extrapolate what are those data elements within the claim that have touch points within the patient's end-to-end journey. When you're able to start mapping that, you're then very quickly able to understand, hey, what are, even for a non-RCM expert, what are the things that maybe are missing in your end-to-end journey that you now need to develop and create that could have resources or tools or vendor implications? And then what are those components that you know are going to be a part of that end-to-end journey? And therefore, where do you maybe need to leverage vendor resources, as well as potentially hiring for maybe some of the administrative tasks that will take place? So as far as like hiring out of the gates, I would really look at your first best path forward would probably be looking at clearinghouses or RCM solutions, specifically ones that could offer a type of hybrid model. Consulting with them, as well as looking at scoping them out for a potential solution for your company, is a really good way to get that understanding of the life cycle of a claim, what integrations are necessary and required. How do you want to source that either internally or externally?
And you mentioned a hybrid model in there. Can you just elaborate a little bit on what you mean by that?
Yeah, so hybrid model would be something in regards to, are there certain components that is important for your business to keep in-house and have more of those controls over? So that could be anything from cash posting and collection to patient invoicing and collection for the remaining balance after insurance adjudicates to collect those copays or unmet deductibles. It kind of explains that. So do you want a hybrid model where you can fully outsource a lot of those components to vendors, or you can find a solution that will allow you to hybrid and kind of piece apart some of those components?
Got it. Cool. And you touched on technology. So Alejandra, I want to come back to you on this. Are there specific solutions that you'd look to bring on right away? So for example, many EHRs also have a practice management system built in. Would you be thinking about, should I leverage that? Should I look for external solutions? Like, how do I think about the technology stack that I should be looking at?
Yeah, maybe just to build up on Megan's question for a second, I think it is worth it for you to find a friend that knows about this, whether you have to pay for that friend or call a friend, but you definitely want their opinion outside of the vendors. Because one of the things that is really hard about RCM is, what exactly do you do and how is it different from the other vendor and the other vendor? And to ask that question to a vendor is really hard. You're asking me what is it that I don't do? And that's unfair for everybody involved. So find a friend, get a friend, it will help you, it'll save you time. After you find a friend, on the technology front, it tends to be, I look first and foremost, what are your anchors? So you mentioned one of the anchors. You have an EHR, great. Which EHR is it? If you have Epic, it's not much. You probably already built it all. There is a lot that you can add to Epic, but you have a bunch already. Unlikely for you to have Epic because we're talking about startup land. So you don't. So what is it that you have? And that is your first anchor. So I want to analyze from a technology point of view. The second anchor is your patient app. Like, again, what is it that we have to do? What is it that the patient is going to find out about this whole RCM mess that we're about to create? And so once you have those two anchors, then the technology follows. You ask very, very important question, which is, should you favor the practice management system that your EHR already has? I don't. I can see the convenience of it. I just mentioned Epic as an example. So you have a monolith, great, you have it, go for it. I find it that over a long period of time, it leads you to use the easiest solution versus best of breed. And technology at this point is able to interact with one another in a way that you should be able to get best of breed, whatever is best for your organization. So assuming you go down that strategy, then the first technology is an eligibility vendor. Change Healthcare, Cermed, there's actually too many. Look up eligibility vendor. You can go through them. And the eligibility vendor is going to power your patient app interaction. So that's the first interaction I'm going to get. And again, I should be able to go live with a mixture of that and some mixture of pricing. Everything else I'm going to figure it out. I might even do it by paper. I don't know if it's even legal. Megan, is it still legal to send that paper? Like, you can try. You can try if you want to. But those are the components that you cannot launch without. So something internal, external to house your contract terms and your contract complexities. An eligibility vendor and a patient app are probably the main components I would look for right from the get-go. And then immediately go after what is going to be your practice management system and what are building house, outsource, and all that fun dance.
Got it. All right. You touched on a bunch of things that we'll circle back to a little later in the conversation, but I want to go to Ali for a second and talk a little bit, kind of as you're moving out of this initial startup phase, what issues do you typically start to see emerge as provider organizations scale? And is there anything that you'd suggest that people do to start trying to get in front of these issues earlier on?
Yeah, I actually think a lot of them have been mentioned already, but I think as with anything, there's, three big categories, and that's people, process, and technology. And we've kind of hit on all of them already, just organically, which I think is just a testament to how much they play a part in a revenue cycle. I think traditionally revenue cycle has been very, very people oriented. Sometimes when I say you peel back the curtain of revenue cycle, it's really people at their desks doing their work. And more as provider organizations have become cost conscious and really looking at efficiencies, we've looked at technologies to plug in for some of what people are doing today. And so when I think about scaling an organization, it's really thinking about that strategy as it pertains to people and the process and technology. So having a really tight and crisp strategy about how are you going to use people, to Megan's point, like, is it a hybrid structure? Are you outsourcing? Are you hiring? That's actually something that a lot of organizations have been struggling with post-COVID, is finding people to fill these seats. And then the technology that you're using, is it doing what it's actually saying it's doing? Is it going to save on the people cost? Or again, peel back the curtain, is it just more people doing the jobs over there that they're saying technology is actually doing? And then really, I'm a big process I'm a big process person, but I think rev cycle is a lot of process. In order to get reimbursement, in order to make sure that you're cutting costs, it's making sure that you have really crisp processes. Something that I know we were emailing about before, I think if you're scaling an organization, making sure that you're operating efficiently can come down as simple as looking at industry benchmarks. So there's a lot of organizations out there, HFMA, MGMA, NAHAM for the access side, that can really check you on, are you operating efficiently? Do you have the right productivity standards for your staff set up? Are your metrics where they need to be? And then the analytics obviously follow that as well to help you scale.
Super helpful. I want to come back to the people side just for a second. And this is for anybody who wants to take it, but is there a best practice, or would you have a recommendation on, when you're just starting, like, would you look to primarily outsource? Like, would you look for a hybrid model? Would you look to hire like one person in-house who's an expert who could then support the external team that you look for? Like, how, like, if it was you guys making this, or Megan, it is probably you making this decision today with your company, like, how would you think about that question? Because I think it's a common one for folks who are just getting started.
Yeah, I'm happy to jump in first. Love the thoughts from Ali and Alejandro as well. But in my experience, and granted, I'm in revenue cycle management and operations, so I'm also probably very biased. But know that with expertise in revenue cycle management and bringing it into a company is really advantageous and going to ultimately set you up for success earlier in the process. Always aware, right? It's not all, you can't always hire that early on, but I think to Alejandro's point, if you can be friends, find your friends with those experts, and then hopefully eventually turn that relationship into an employee type of partnership, or even long-term consulting. You can leverage this person to really help draw out what that strategy will look like. I've seen even success with that minimum an experienced RCM manager that can really help at least evaluate some of the tools and vendors that you're looking to bring on to support the life cycle of a claim, as well as maybe some of the gaps within the patient journey that are required to support the support of the life cycle of the claim. And that person then can also really help to develop that strategy of then looking long term of maybe you're starting with very manual processes, to Ali's point. Sometimes it is a maturity walk, right, or maturity steps of where are these people behind the curtains that's necessary maybe for the first volume as you're ramping up, and then what does that look like as far as a timeline as you want to get to scale, and someone with that experience and expertise early on can really help make sure that long-term vision is always being thought and pulled throughout the process of the stages of growth.
I'll say my hack is to try to hire Megan. It's one way that's not scalable. So the way that I've seen it, and I feel like your question is extremely important, and yet is one of those impossible questions. It's like, how do you find a significant other? Like, depends. Works out for different people. But for me, what I have seen with the clients that I've helped is, first of all, you have an athlete, tends to come from either operations or finance, that is able to go and like, you're going to figure this out. their call is like, I want you to turn us from direct to consumer to B2B2C, or some prompt that is awfully generic. That athlete will bring different experts depending on what they find is the hardest thing for them to figure it out. And eventually they both come up with a bit of a business model thesis. And that model is super important, because the first thing you got to ask yourself is, am I talking about 50 claims or 5,000? It's a very different set of humans that I'm going to need. And once you have that answer, there's like, well, the first thing that it breaks is, I don't have enough humans to file 5,000 claims. So now I need an RCM director, RCM manager, and you start like going down the pipeline of titles. But if you're like, I need 50, like I need somebody that knows enough, but is willing to be flexible enough to do all the roles. Because RCM tends to be a function of hundreds of people. I need some human that's able to go from all the way to registration issues and provider credentialing, all the way to refunds. And that human is hard to find. But that's where ultimately becomes very specific to the organization. What is their best path forward as it relates to timeline? Ultimately, everybody ends up with a similar org design, but how fast you move through that org design is super personal, in my opinion. Ali, I don't know if you've seen it differently.
No, I would +1 everything that was just said. That was going to be my exact response. I don't think there's like a one size fits all response to whether or not you outsource. And I think it's so unique to where each organization is and their size at that time, and also just what they're motivated by and what they're trying to solve.
Mm-hmm. Makes sense. Super helpful. Cool. I want to start to dive a little bit deeper into some specific areas kind of within the end-to-end process. So Megan, I'll come back to you. I know you're a big believer that getting the front end of the revenue cycle right is particularly important. So can you talk a little bit about what goes into this part of the process, and specifically, what you do to make sure it goes well?
Yeah, happy to. So love to start with the stat, a 2022 study across more than 1,500 healthcare systems, analyzing roughly 440 million institutional and professional claims, still showed front-end denials are making up about 41% of all payment denials. Many of these are preventable when investing in the right vendors and workflows at the beginning point of the patient's journey, which is the patient intake and eligibility. There's a ton that can go into this process to improve not only cash collection rates, sometimes even conversion, mostly retention, but they start with the ability to check a patient's insurance in real time. And I want to, specifically harp on the real time. It's a crucial first step. It's not only to determine the right payment journey for the member. Are they cash pay? Are they leveraging in-network coverage? But it's also to ensure you're routing patients to some, as simple as routing patients to providers' schedules who are in network with their specific health plan. Another piece that comes into play kind of full circle here with understanding the components and data elements required to go on an insurance claim. You can also store required insurance claim elements from the eligibility response. That can be extracted to build a clean claim. A clean claim is also known as just an error-free claim. It is submitted and accepted by the payer on the first pass, not rejected or denied. And so there's examples of that, of like electronic identity, who is this health plan via the trading partner ID, the patient's legal first name, their legal last name, their actual insurance member ID. I think this also comes back to Ali's example earlier of where right now there's just so many humans. I think that's also why this denial rate at 41% is still as high as it is, because we're still in this industry so much reliant on humans entering the information, actually data entering the information that they take from the member from registration, or they're just taking the member's information verbatim, or they're having the member input the information. So there's tons of room for error. And that's why these are such preventable denials, because they're essentially core data entry denials.
Is there anything to do about that? Sorry to interject.
Yeah,
is there anything to do about that, or is that just like part of the issue? You either have a human taking it over the phone and there's issues with that, or you have someone type it in themselves and they're going to typo things. Is that just part of the process?
there's a level to that, but I think that can be so much more improved by leveraging tools and vendors. And so really looking at who provides the most robust and experience within real-time eligibility. Alejandro hit on this a little bit as well. Is that a clearinghouse? Is that an RCM solution? Not only just looking at what the robustness of their API and ability to support the function, but even also, especially when you're starting early on and maybe don't have expertise in this space, also leveraging them of what do they know about the workflows that go into that real-time eligibility? How do they understand how that information also helps the back end, right? The compensation component and what needs to go on that claim. And then I'll end on a bonus of that when you're evaluating vendors or a partner in this space. Do they also understand cost share estimates? Do they have a tool for that or a solution? Because that's definitely something as we think through the importance of price transparency within this industry that can come into play and be a real benefit for your business.
So it's super helpful. I'm going to jump to now the back end of the cycle, and so we'll talk about patient collections for a second. So Ali, I'm going to come to you. Patient collections is something that's obviously become increasingly important in recent years, just as patient deductibles have gone up. So any recommendations for companies as they're starting to set up their collections capabilities?
Yeah, so patient collections has been my bread and butter at Cedar for the past 3 years. So happy to talk about this phase. I think one thing, Bobby, you just said that's really important to note is more and more of the cost share is being put on patients today. A lot of that is due to high deductible health plans, but just because we're shifting to more of the cost being put on patients does not mean that their ability to pay has changed over the years. So I think that's a really important part, and one that we're digging into a lot in my work is why aren't patients able to pay their bills? And so when we think about collections, I know all of us have probably had these firsthand experiences with either with ourselves or with our family or friends where people have an acute healthcare episode and they think first, about their health and second about how much is this going to cost. And so I think there's a couple of things we can do to really set up great collection practices. And one is transparency. Megan said price transparency, which is kind of a buzzword right now, but I'm thinking of it in the literal sense. I think the more that you can surface estimates to patient, even just a ballpark at the front end of the revenue cycle, the better it will be to get them to pay their bills and allow them to plan for those. I do think there's a culture shift. There are some organizations that do this today, but there's also patients who don't want to think about it until 3 months after their service because they're used to that. So it's definitely going to be a shift, but I think the more that we can be transparent, the less it hurts when you actually do get that bill. I think there's also transparency just in terms of being able to tell patients, you have this much money in your HSA or FSA. We know a ton of HSA and FSA dollars go unused every year, and that's something that patients could use to resolve their bills and take away some of the stress. And then it's also connecting them to financial assistance where it's available and putting that right into the bill pay experience. So that could be Medicaid, that could be right now, it's November 1st. So we just kicked off ACA enrollment. It could be just charity care as well at the provider. But I think the more that you can service that within the collections process, the better. And then I think we're just getting to flexibility and patient-friendly billing experiences. So more and more as consumers, we are having really, really good consumer experiences when we pay for other services, and we're not having those in healthcare necessarily. So I think at Cedar, some of the things we're doing is making sure it's really flexible just in terms of your options. I will choose Apple Pay over any other option if it's available to me. And I want that in my healthcare experiences too. But I know my mom and dad don't. They still want to mail in that check, right? So it's really being flexible to all of the options and really meeting patients where they are and making it just really easy to resolve their bills, whether that is financial assistance or is that a flexible payment plan option that I can just set up in a few clicks. So I think the more that you can meet patients where they are, be flexible, be transparent, and make it easy to understand without having to have 10 years of revenue cycle experience is really important when you think about collections.
That makes a ton of sense. I'm going to continue to bounce around. We're going back to the beginning. So Alejandro, I want to come to you and ask about contracting. So, obviously an area that confuses a lot of folks when they're just getting started. So can you talk about a little bit about what this looks like for most early stage provider orgs, and even like how to think about whether negotiation is even possible when you're just getting going?
Awesome. Yeah. Thank you for the question. I realize this is a self-selected group that already said like how the over revenue cycle, but I just want to acknowledge all of this is a pain. It's much easier to collect a credit card. Like you might also feel tempted to be like, I'll go direct to consumer, everybody else deal with your claim. And that's fair and not scalable. Like I just want to acknowledge like all of this conversation is one of those that you have to, as part of the US healthcare system. You can try change public policy, but you have to. And once you get through that feeling, it's actually much easier. And that's the first thing that I want to acknowledge for any new company going through this is like, this is going to be hard and you have to. So go ahead and let's get it done. On that, you have almost, I'm going to be very reductionist. So this is not a full strategy. Find somebody that has a good strategy, but very reductionist. You're going to get money from the public sector, and sell directly to the government, or the private sector. 99% is a bunch of startups. You're going to go for the private sector. Then you're going to split that, and you're going to say, am I getting that from the health plan's pockets? Let's call it fully insured. That is actually like money that the health plan will be giving you. Or am I getting it from employer's pocket, which might be through the health plans, but it's employers. So I'm selling to the Fortune 500 companies. They have a budget. They have a medical budget. They have a discretionary budget, and I'm going to figure it out how to sell to them. You go through that pipeline. I have found that the highest level of innovation for very early stage provider organizations is going to come from the last bucket. So it's the employer bucket. These are naturally companies so large that it's worth for them to try out anything that would avoid this trend of healthcare costs going up 5 to 7% every year for the past 30 years. You want to avoid that. So assuming you go to them, there is going to be super reductionist, but there is going to be 3 contracting patterns that you got to figure it out. I'm going to go directly to the employer. I'm going to say, hey, I have this widget that is awesome for your population. You should pay me directly. And that's just an invoice, fairly straightforward, difficult sales cycle. The second one is, hey, I have a widget. This is great for your employees. And don't worry, I'm going to send claims to your health plan. They're going to process and pay from the medical bucket. That one is a little bit harder, but that's what we'll call a vendor contract. And your contract will either be with the health plan and the employer, or the health plan to the employer, or just the employer and then the health plan on the side. You'll figure it out, but ultimately you're a vendor contract. And then the last one is a little bit more closer to a broad strategy. And you're saying, look, I'm providing something of significant value that is broad beyond any employer. I want to go for, I just want the health plan to pay me whatever it is that they pay for this thing that I provide. And that's just an in-network contract. Now, the delta is that an in-network contract, you're playing within the guardrails of the industry. You're like, hey, I do that thing that you say you want me to do, and here's the CPTs that I do it for. Here's the location, pay me. It's almost like if you open a brick and mortar clinic, and you can do that strategy, assuming that those rates are good enough for you to run your business. The minute you get out of that, then you're looking for more of a sales cycle. It's a strategic sales cycle where you are convincing somebody that you're going to add so much value that it's worth changing the guardrails. One example that I've run into at different companies that I've worked on is every time you use a type of clinical model that hasn't been broadly accepting, like coaching for mental health, you likely will have certain moments where like, well, there's no CPT code that fully matches what I want to do. So then I need to speak to somebody. And naturally, that speak to somebody translates to a vendor contract. Not all the time, but many times. Not sure if I answered, but happy to go into a different rabbit hole.
No, it's super, super helpful. I do want to just dig in on the going in network piece of that branch for just a second. Is there any scope to negotiate those rates? Or are you just basically, for most, again, early stage, are you just a price taker of whatever their standard reimbursement rate is?
Megan, I want you to keep me honest. I made up in my head that if you're going in network with a provider contract and you don't have dominating power over that service line and or geographic location, then you're likely not going to negotiate those prices. Megan, Ali, can you keep me honest?
Looks like shaking their heads. Yes.
Yeah, that's been my experience as well.
Got it. Okay, cool. No, super helpful breakdown. All right, continuing to bounce around. Let's go to managing rejections and denials. So Megan, coming back to you, any best practices just for officially managing rejections and denials once you started submitting claims? And then I'll have a follow-up after that, but well, let's just start there.
Yeah, I think the best practice is, and this will seem silly because it's kind of a no-brainer with all of us in this industry that are probably very data oriented, but it's to really categorize the rejections and denials. And I think why that is significant to note here is that I think tools are just starting to understand the importance of what we call in this industry accounts receivable work. Traditionally, for a very long time, it's been task-based oriented. So that's like a claim by claim review and follow-up type of workflow, as opposed to more of that strategic understanding of, no, I want to be able to have these denial codes that come back from the health plans mapped to categorization so that you can, as an RCM leader or manager in the space or vendor that's overseeing the denials and rejections, what are those trends, right? You want to be able to draw insights from the denials and rejections in order to take actionable steps to actually not only work them, but then prevent them right upstream to where you can. And you can't do that unless you have those insights. And so one of the things that has been a challenge in this industry, at least from my experience on the operations side and managing teams, is that so much of this has lived in spreadsheets. And so it's very important to find a vendor or partner that can help you get out of those spreadsheets and really leverage their tools and technology where you can really customize that task orientation workflow for your team, your revenue cycle team that's working the rejections and denials, to not only be able to draw conclusions and trends to work things upstream, but also work those in then a very efficient manner. So it's not just a claim by claim basis.
Makes a lot of sense. And anything else you'd suggest around, I don't know, how you might prevent like as many rejections and denials? Like, do you see common mistakes that people are making when they're just getting started that wind up leading to a lot of rejections and denials?
Yeah, I mean, I want to say, like, rewind to my TED talk about intake and patient eligibility. No, seriously, I think, I mean, that's one of the biggest, things to look out for to prevent early on, as much as you can with getting things out, the things that you can build and get right out of the gates as far as patient eligibility and intake. And then I would say from this piece, really looking at, what is your understanding your business model and what your clinical offering is going to be, because that will also then help dictate what truly are covered services. What are those covered services with my health plans that we have contracted and are in network with? Are the providers, linked, and are they also in network and effective in the payer system? So you can start to prevent those more simple, what we call preventable denials of like patient, provider not found or ineligible for data service. But those are then where, if you have a robust system that you can start surfacing those trends and categorizing them, you can quickly identify, hey, by fixing this one thing upstream, that's going to, help alleviate a backlog of, $50,000, let's say, or something, or probably a lot higher. But you can start to get those quick wins just by analyzing those trends and then implementing workflows early on so that you can prevent those types of denials from happening in the future.
Makes sense. One more quick question, and we'll open it up to the audience Q&A. But it would not be a webinar in 2023 if we didn't ask about AI. So just curious to get this group's take on where you guys think AI is going to have the biggest impact across the end-to-end revenue cycle.
I think maybe on that last caveat, so I'm going to put an investor hat on. Like, I'm going to put in the money. If somebody comes, I'm going to automate revenue cycle management with AI. I'm like, you're not. However, if somebody says, hey, I'm working with hospitals. That's one. And this is really important because this is high volume. So I'm working with hospitals in a way that fixes this particular area of revenue cycle. for this particular service line with AI. But let's talk about it. So a few examples that I've seen an attempt to do it, and I don't know how impactful it is. You've seen it in pre-auth. People are trying to automate pre-authorization processes. It's a little bit funny when you think about the payer automating the response to AI. It's just bots talking to one another, probably in the future. However, I do think whoever builds best-in-class AI tools for a given problem is going to be amazing. So I talked about cost estimates. A lot of people are good at cost estimates, but the person that does cost estimates based on truly flexible intelligence for a service line, for a given set of contracts, that's going to be amazing. Because most of the cost estimates tools are really smart, but they're static. So that's one area that I'm excited to see. And there's 1,000 areas. Basically, anytime you see a human doing the same thing over and over again, I bet there's a ton. So one of the questions that came up is like, well, why? I think the question basically is like, why did Olive fail? I'm like, it's too hard to go after it. It's too hard to try to cover everything. But I do think it'll be extremely impactful for those that specialize.
Yeah, I can jump in here. I think where a lot of people's within revenue cycle go is the authorization side. To Alejandro's point, it is kind of funny of bots speaking to bots. I actually, just being in rev cycle, and I sometimes tell people I'm a bit of a pessimist for that reason, but I try to have a really optimistic view on things. I think one of the places that I'm most excited for, especially because we've talked about the people challenges so much, is how can we use AI to guide people doing their jobs? So it's not necessarily replacing them doing their jobs. It's not replacing them doing authorizations, but how can we use LLM to say, like, are you sure, like, it looks like you made a mistake here, and put them back. Or if they're talking to a patient, how can we allow call center staff to talk to them in a way that's the systems really back up what they're doing and eliminate some of those human errors. So that's where I get more excited. It's not the exciting part necessarily, but I think it's like a bit more realistic of where we can use it right off the bat.
I'm with Allie. Like verbatim.
All right. Sounds good. Well, why don't we jump into the Q&A then? We've got a few questions to run through. So just go in order here. Whoever wants to take it, what general recommendations would you have for RCM for a company that's currently in a cash pay space but is trying to move into payer partnerships and insurance reimbursement?
Find a friend. Okay, but this is for real. Like you're about to change your entire business model. Don't try to find a vendor to do that. Find someone that you trust, someone that has done it before, a consultant that has done it before. But this is not, you're not at the level of vendor recommendation. You're about to change your entire business model. So have somebody that you trust.
Just to unpack that, like, is it, I mean, what it literally do? I'm going to start with, I happen to know this other digital health company. I'm just, talk to this person I know there and see how they did it. Would you be looking for a consultant actually to bring on to spend, some sustained time with you? Like, definitely get the talk to an expert essence of what you're saying, but just curious if there's any practical recommendations there.
Yeah, I just had a call earlier this week with someone that sells tests and services for a particular disease state, and they do it out of pocket. And they charge an amount that is great. I think it's a great business model. And that amount cannot be translated to any health plan. You just can't do it. So now the entire tech stack is about to change. The entire set of humans is about to change. And somebody needs to answer the question that I started with. Are you going to sell to employers? Are you going to sell to insurance? Are you going broad? Are you specialized? Now I'm defining your business. Now we're defining pricing strategy, value proposition. And that, I don't trust any vendor. So it depends on your network. If you have zero network, then you will have to pay for that consultant. But I bet you have somebody in your network that has done something similar, and you can start putting the pieces together. Ultimately, you as part of that company need to stop yourself against this problem because it's big enough that it cannot be fully outsourced, in my opinion.
Yeah. Cool. Next question. What vendors tools do you recommend for real-time eligibility? how do you confirm they're actually in network with the providers versus just confirming that insurance is valid?
I'm happy to take that one, Alejandro. Curious your side from the product and integration piece, but from what I know on the operational side, as well as some of the API integrations, Change Healthcare and Waystar are probably the top two vendors in this space. They also offer, if you're looking, while you're looking at some tools, RCM solution tools that already integrate with those partners for like their claims clearinghouse. They might offer pass-through APIs for the eligibility connection. But those would be the two that I would look at. They have the most, probably the most payers that they're integrated with. So if you're going full scale, and you know that, to Alejandro's point, you do define what your business strategy is, and you are going to go in network or have a bunch of employers that are going to have a lot of payers that you may need to integrate with for eligibility. Those would be the top two. They also have some of the most robust APIs. How do you confirm that they're actually in network with the providers versus just confirming that the insurance is valid? That's a great question. So as you start to look into the world of real-time eligibility and the information that comes back in the eligibility request, there are specific segments that come through that you can read. So you can essentially look to say, what is the plan status? Is that inactive or not inactive? You can also look to see, what is the insurance type? Is this a commercial or a government type plan? Is this an HMO? You can then even get into the weeds and start looking at things that are specific to how your contracts are structured. Are there employer group numbers that you need to keep in mind? Are there specific plan types that come back in the segments that you need to keep in mind? So there are many things that you can do with those eligibility responses to get the specific in-network coverage that are specific to your contracts.
Great, super helpful. We'll keep going here. All right, so more specific question. In looking at collections from patients and why they can't pay, do you look at complex claims? Things like, I was gonna say PIP, MedPay, third-party liability, workers' comp, et cetera, especially since health insurers will try to deny these.
Yeah, I can take this one. So I think working at Cedar, we are a vendor, so we're limited in the information that we do get. So a lot of times it's going back to the provider and helping them diagnose sometimes, like, why is your self-pay patient population going up? Since we are at liberty of the integrations and the data we're getting from them. We do specifically look a lot at what we call BAI, balance after insurance, and then the true self-pay patients, the patients that don't have insurance, and try to differentiate the two, because collection rates on the two vary very drastically. And I think everybody on this call probably can infer why. It's unemployment, it's not being able to pay even $100 bill, but it's also that, unfortunately, self-pay patients aren't getting $100 bills. They're getting $5,000, $10,000 bills, and the affordability just isn't there. So we do look at those things. I think just with the current macroeconomic environment, we're starting to look at other things too. We're looking at inflation, and we're looking at unemployment rates. We're looking at zip code level data, and we're even starting to explore sentiment as well. So was it a TikTok video that told patients they don't need to pay their bills? I think there's a lot of things that data can tell us, and then there's things that we do need those consumer insights to tell us as well. And that's where it gets a little tricky with patients, is it's not as straightforward as why is it the insurance company paying? We generally do have denials to tell us what went wrong there, and we can fix those. With patients, it's a bit more of a puzzle to put together.
Got it, helpful. Looks like a few quick questions I'm going to bundle together because they're all kind of in the same practical space. So 1, do you auto charge patients for their balance after the claim is processed? 2, when do you charge the copay? And 3, any recommendations on financial assistance programs?
Yeah, I can take some of these as well. So we do not auto charge patients. There are a lot of providers out there, a lot in more of the startup space too, and a lot on the behavioral health side that do have kind of the culture of, we're going to charge you, and that's just what you get by going to this provider. But I would say I haven't seen that the industry shift to that from a wide scale, just healthcare provider and big organization perspective. I would say copays should be charged absolutely on the front end. That's really easy money to get up front. Do it. We do have really high collection rates on the back end with copays, but it's way better to get cash sooner. So charge the copays up front. And then financial assistance, I don't know, Megan or Alejandro, if you have any suggestions. We typically are working with larger health systems who have their own financial assistance programs. But if there's any suggestions from either of you.
I will have to go back to my hospital days if I think about financial assistance programs. So at a professional billing level, I don't know if I can add much value.
Got it. Next question. Who do you guys typically see lead the purchasing of products built for RCM? Is there particular team members or departments that you tend to see do this most?
Say it depends on your stage. So like first and foremost is who was the athlete that decided to deal with this thing? And it tends to be, again, within the finance and operations department. So the first set of purchases are coming from there, super early stage, and then specializes very quickly. So when Megan and I work together, I'm likely going to have a ton of opinions on the eligibility vendor because it affects a ton of engineering's time. But Megan is going to decide practice management systems because ultimately her team is the most affected by both the performance and the impact of the tool. So I think it breaks down very quickly. I think as you grow, there will be multiple vendors that different departments within the hospital will buy, and you have a number of purchasing agents.
Makes sense. Let's see, next one. Is there, where is it? Is there a need for AI to help identify missing diagnostic codes for value-based care risk adjustment factors?
Good question. It's definitely, I would love to see that come into play. I think to that point of like, what does that look like? Can it get that prescriptive? But I think today, right, it's mostly humans. And so I think there's definitely there would be a very welcome need for that.
Got it.
Not only just value-based, to be honest. I mean, anything that has that you can see in denial trends and rejections where there's missing ICD-10s or even the order of ICD-10s, if we could leverage AI or some type of automated rules to come into play to help clean those up ahead of time before the claim is submitted would be ideal.
Makes sense. I'm gonna hop around a little bit now. Going back to the people component, this is a good question. Going back to the people component, what is the best way to recruit a revenue cycle management associate? Any good candidate profiles to look for?
Yeah, I can take this one. I'm actually looking for some RCM candidates currently. So I think when I think about hiring for RCM associates, it's really, what are you trying to achieve? Is it somebody who's worked directly for a provider organization? Those folks are generally going to be really, really skilled in the details. And those people are the people that we lean on most often, I feel like. I worked with a handful of them who have made their way into consulting or into tech, and they are just so helpful. So I think it's really what you're solving for. I do think, I'm probably biased, but consultants in the rev cycle space have seen a lot of different organizations. And so they're able to offer that perspective. They're changing projects every few months. And so I think that's really helpful as well. So I would say one of the two, but somebody who's really knows the ins and outs of rev cycle is important.
Yeah, I totally agree with Allie. And I think even to go in a level of detail, if you're looking at LinkedIn, for example, and titles, reimbursement specialists are generally RCM experienced employees that have that full end-to-end kind of experience within a clinical setting. And then if you're looking for, if you know something that you're trying to solve, which is denial management, or you need a really robust billing athlete, I'm going to use that term now, Alejandro, thank you. That might be a medical biller, or if you're needing coding expertise, a certified coder. So you can even get prescriptive of what you're looking for as far as titles of people's experience, but a reimbursement specialist generally has that end-to-end life cycle of the claim knowledge.
Right. Well, we're just about at time, so we'll end things there. But a massive thank you to our panelists. There was a ton of good knowledge shared here, and yeah, really appreciate everyone's time today. Enjoyed it, and good luck on your RCM journeys.